turn to small cell lung cancer, where there was also some work with immunotherapy early days. Jean-Charles, what did you think of the data with Keytruda, pembrolizumab in small cell lung cancer?
Well, I think this is, again, very important and promising data, correct? I mean, small cell lung cancer is a disease where frontline chemotherapy works in 80%, but unfortunately relapse is the rule. And this is a very frustrating situation. And we have been trying targeted agents and anti-angiogenic compounds for the last 15 years with zero success. And it is extremely important to see monotherapy activity in that setting, correct? Because after failure of platinum etoposide, we have not much. At least what we have as a standard, it brings limited activity with a lot of toxicity. So therefore, I think this is very important news for the small cell lung cancer patients. In the 80s, it was better to be a small cell than a non-small cell. In the 2000s, when you tell someone he's a small cell, but that's bad news, correct? And now, I think with the activity that has nothing to do with PD-L1, because they are completely PD-L1 negative, the small cells. But they have a huge mutational load, which is highly related to tobacco. And I'm very happy to see that trials are ongoing. I don't know the trials that are ongoing in the US, but I can tell you that in Europe, Merck, in collaboration with the EORTC, which is the European Organization for Research and Treatment of Cancer, is launching a phase 2-3 trial of chemotherapy followed by maintenance pembro versus chemotherapy. And I think this could be very, very important. It has the potential, in my opinion, to potentially change practice in small cell.
What do you think, Dana?
I agree. I think that the bar is even lower for small cell than for squamous cell. We need to do a lot better than what we have. There's really nothing in the second line that has any, I think, meaningful efficacy without severe toxicity. And I was very encouraged by the results that we saw at this meeting over this weekend. And I think there's a couple of key points, though. I don't think that we know what the role of PD-L1 as a biomarker is for small cells. So the patients in the pembro data that were presented were actually all selected for patients who were positive. So they reported a rate of about 30% positivity, actually, at a low level. The bar was 1%. So again, taken in context of other pembro data, where 1% in non-small cell lung cancer doesn't necessarily lead to improved outcomes, it was pretty impressive that we were seeing significant response rates on the order of 35% with that level of expression.
The problem was that it was in a whittled down population.
It was a whittled down population, absolutely, and whittled down for many reasons. Very selected, because I put patients on that trial. We lost many patients because the time to get that biopsy screening, determine positivity, we lost a lot of patients.
Well, that's a real practical issue.
It really is a practical issue.
It is in second line anything, but certainly in small cell lung cancer, there's not a lot of time to wait 2 or 3 weeks for a result to come back.
That's where I think that the other trial that was presented, the Nivo versus Nivo ipilimumab, will be even more interesting potentially. So we know that in trials of CTLA-4 antibodies alone, there was more of a hint of activity in small cell versus non-small cell, where I don't think there was really any hint of activity. And the combination, which was presented here as well, also has very encouraging activity in patients who are not selected by PD-L1 status. I've put many patients on that trial. They go on right away. And I mean, this may be sort of anecdotal because I've seen remarkable things. People living for so much longer than they would live normally with small cell lung cancer and with minimal toxicity. And that's something I think that is key. I do think that we may see differences in toxicity that are context dependent, but for some reason, small cell patients to date have not had the burden of toxicity that we've seen for melanoma. And it might be completely the fact that it's a very small population that's been tested. We may see all the same things happen. I don't know. But it's sort of encouraging so far.
But it may be that the mutations they have are different, correct? And they cross, the cross-reactivity with self-antigens is lower. But the mutational profile you get from sun exposure or tobacco exposure or other exposure might be different. And we're going to learn. And this is going to be pretty interesting to figure out that.